Hello, and welcome everyone. Thank you for joining us for today's NSWAC and Walk Institute Continuing Education webinar. Today it's titled From Habit to Healing, Rethinking Wound Cleansing in Canada. And we're so happy to be joined by our guest speaker, Karen Laforêt, today. Before I introduce our guest speaker and our moderator for today, I want to just go through a couple of housekeeping items. First things first, let's get everybody to click on that chat button in your Zoom toolbar and let us know where you're tuning in from today. I know we've been getting quite a few people from across Canada, of course. We've had some of our American colleagues come by too, and even in South America. So it's always interesting to see who's coming on here. We've got Windsor, Ottawa, Kelowna, Kamloops, Gatineau, Fredericton, all across Canada. We love to see it. Thanks for coming, everybody. My name's Troy. I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm so thrilled to be with you today. It's our last continuing education webinar before we have a bit of a summer break and return back in September. And we want to say thank you so much to Ergo Medical Canada for making today's education possible. We couldn't do this without you, and we appreciate your continuing partnership. We want to remind everybody that we're going to be offering French translation of today's webinar. It's live translation using a tool called Wordly. And in the chat, I've just pasted the link you can use to join. We also included it in the webinar description. But if you'd like to listen in French or another language for that matter, you can click on that and follow along live. We're also going to be doing a Q&A portion at the end of today's webinar. So if you have any questions today, we're going to use the Q&A button. So not the chat, but the Q&A tool in your Zoom toolbar, and that'll make sure we can get to as many as possible at the end. We're also recording today's session, so you can watch it back after the fact, or if you have to head out early, you can always catch the end of it later, and you will be receiving a certificate of attendance. So just give us a day or two, and we'll get those into your inboxes. So without further ado, I'm really excited to be introducing our guest speaker today. Karen is a master's prepared registered nurse with more than 35 years of clinical experience in critical care nursing, community nursing, and clinical education, both nationally and internationally. She has a strong background in skin health, complex wound management, and infusion therapy. Karen's currently employed as a clinical educator, focusing on wound management and infusion therapy. And in addition, she's a clinical consultant for a number of companies that support professional practice, program development, and clinical training. She's an active member of numerous professional organizations, including Wounds Canada as co-director for the Unregulated Care Providers Education Program, the American Professional Wound Care Association, Association for Vascular Access, where she's currently the president, National Coalition for IV Medication Safety as a board member, and others as well. She has been on a number of clinical practice guidelines committees, consensus panels, and is on the editorial review board for multiple journals. So we're really pleased to have you here today, Karen. And joining us as well is Dr. Debashis Chakravarty, who is a Vice President of Innovations and Medical Affairs with Ergo Medical Canada. And he's going to be helping out with some of the moderation today during the Q&A portion as well. So we're grateful for his guidance as well. And with that, I'm going to pass over the mic and the slides to you, Karen. Thanks for being with us today.
Thanks, Troy. Thanks, everyone, for joining us today. I'm really excited to be here to share information and knowledge with regards to therapeutic wound cleansing. So for today, we're going to talk about gaps between current cleansing practices and evidence-based guidelines, therapeutic wound cleansing and its clinical importance in wound healing. We're going to explore new international and existing recommendations for cleansing solutions, including the use of pure hypochlorous acid. And we're also going to look at how to integrate guideline-based protocols into practice. Before we begin that, we're going to do a first poll, and that poll is, which will help me, and help you to find out where everybody's working. So if you can just sign in and let us know what care settings you primarily work in. And hopefully I caught most of them. So is it hospital, outpatient clinic? So something in the acute care outpatient world, primary care, so Ontario health teams or something similar, whatever province you're in, community, home care settings, home care nursing-based clinics, long-term care, or if I've missed something, just put that in other.
Awesome. And you should be able to see the results in front of you now there.
That's great. So we have 29% are from the hospital, 5% outpatient clinics, 3% from primary care, 37% from community home care. Let me see, 6%, very fine print on my little screen here, 6% in home care nursing clinics, 28% in long-term care, and 9% in other. Great mix. I'm glad you're here. And so hopefully I'll be able to address all of the different settings and when we look at practice and how we might be able to implement evidence-based care. So when we think about wounds, they are the final frontier of non-standardized practice to prevent infection. And so really when we talk about cleansing, it really is part of helping to do an infection prevention program. We're well aware that there are infection prevention bundles for ventilator-associated pneumonia, surgical site infection, line-associated bloodstream infections, catheter-associated urinary tract infections. And all of these are really related to a portal of entry into the body. When we think about aseptic non-touch technique, key sites, key parts, right? So trachea, IV site, a wound, those are all portals of entry. And yet, despite all that, and despite the fact that over 50% of all the patients we see have a wound, we don't have any kind of standardized protocol or bundles that help us to prevent infection for our patients. It's troubling, isn't it? So, in order to us to kind of get an idea of why we still have these gaps, Dr. Kim LeBlanc and Kevin Wu evaluated Canadian nurses specializing in wound ostomy continence. They asked questions with regards to the cleansing knowledge as well as practices. Are they aligned with the evidence-based recommendations? So I'm going to share some of that information. Some of you who are on here may have seen this information at the NSWAC conference. It bears repeating because it's quite profound. So we do know that there's a strong gap between knowledge and practice in Canada. So 91% of the respondents always cleanse wounds. So that's great. So, and 75% have that as actually part of their treatment plan. So on average, NSWACs use 4 different cleansers in their daily practice, which wasn't unusual for me. 95% use saline. 58% use hypochlorous acid, and 34% use soap and water, again, depending upon the wound. So that's part of those 3 out of the 4. The top reason why they're choosing a cleanser is presence of infection. So 65%, not necessarily 100, 65%. 56% talked about actual availability of a product, and we all know what that's like, especially in Ontario these days. And of course, 54% did base their cleanser on the current evidence that they had available to them. The cleansing techniques, 60% of the respondents irrigate with saline. It's the most frequently used method and the current standard of care. That comes as no surprise to any of us. 37% of the respondents said that they use soaking as a irrigation or cleansing technique when they suspect biofilm, when the wounds are sloughy, and often hypochlorous acid is often used. So I found that very interesting, these statistics, this information. The key insights and the ones that I wanted to highlight are really like 34% agreed that hypochlorous acid and sodium hypochlorite are equally effective and toxic to healthy tissue. We'll explore that in a little bit later. 54% agree that antiseptic solutions should be used to cleanse the peri-wound skin. 54%. 68% agree that soaking with a wetted gauze followed by mechanical or gentle scrubbing with gauze is the best way to clean the peri-wound skin, which is actually not too bad. It's about 2/3, right? However, only 30% identified that they actually do that soaking. So while they agreed that this is important, only 30% are actually putting it into practice. So you can see that there's a disconnect between what they know to be best practice or evidence-based and what their actual practice is. So our next poll is one that we're going to ask you to put your comments into the chat. And this poll is really, what challenges do you face in doing wound cleansing and your wound cleansing in your environment? So if you can just put those in the chat, Troy will will be shouting those out to me so that I can keep track and hopefully capture some trends.
Absolutely. Yeah, definitely put them in the chat there. We've got solution availability or access to products, availability of supplies. We got a couple people saying availability of supplies and products, quite a bit of those, time constraints, product availability, Disponibility or the availability, solution availability, staff, workload, time and access, cost. Saline is free from the government. Interesting. Okay. Availability. Yeah, a lot of this. Education of staff as well. Shortage of time. Overbook with too many clients. Lots of great answers here. Yeah, a lot of availability. Supply is not available. Teaching on proper wound care and cooperation from the client, staffing issues, product availability, education of staff. Yeah, lots of these similar kind of comments here.
So very similar trends to what we've heard from before: lack of resources, lack of actual educated nurses, lack of actual bodies, lack of actually getting the product available to you. Inconsistency, so education, nurses doing different
Mhm.
things, variability of practice,
Yeah.
the lack of knowledge, like what do I do?
Yeah, not knowing which solution to use. We're getting a couple more of those as well. When it's
Exactly.
best to use what. Yeah.
Yeah. And then, of course, the time piece. Having worked in the Ontario home care setting, and especially in the nursing clinics, we had to get these patients out like this, right? I felt like I was a production line sometimes, and that does impact our ability to be able to provide the best and safest care for our patients. And so we know, though, at the same time that when we are able to do a dressing change and do wound cleansing, it's an opportunity for us to guide the trajectory of wounds towards healing. And so let's look at how we can be doing that. And thank you for all of that great information. It sounds like we're sharing things across the country, unfortunately. So when we think about common myths, right? Because when we look at this is probably, you see this picture and you go, oh yeah, I've seen this. Pouring the saline onto the wound, using a syringe. I really like this little dribble from these little saline bullets that are supposed to be used for suctioning, or like the 10 mil sterile saline syringe that you use for flushing, IV catheters, and kind of sprinkle it on there. These are not therapeutic, right? It's like anointing, dribbling, spritzing, or spraying. They're not therapeutic techniques, which we'll get into a bit later. Um, at the same time, we have to think about the therapeutic cleansers that we're using. We want to stop anointing wounds and truly clean it like we mean it. And so what does that look like, and how do we get there? So as you can see, this is not cleansing, right? I just want to do this little, anointing of my wounds. So the term wound cleansing is used often in the literature and in clinical settings. However, it has not been really well defined. It's kind of like when we talk about aseptic technique. And up until aseptic non-touch technique framework came into being, we were using all kinds of terms to mean something, and it adds confusion to what we've already identified as issues, and making sure that people know what they need to know in order to do the right thing. Historical cultural practices often drive a nurse or a clinician to use outdated techniques or cleansing products and solutions, and unfortunately, it impacts the patient in a negative way. So what's to do? So the highest level of evidence have recognized that there are gaps in our clinical practice, and all of these will come as no surprise to any of you here on this webinar tonight. We know that there's limited evidence exists on the ability of saline to address high levels of microbes or bacteria, right? It's inert. It's like water. It's like potable water, right? Using a cleanser that can remove or disrupt microbial colonies is a critical component to wound healing. The ideal cleansing solution should balance the need to remove these microbial colonies, which is very difficult for me to say for some reason today, while avoiding damage to key wound healing cells, right? So we want to support wound healing, but at the same time, get rid of that dag burn pathogens that are in there disrupting everything. Traditional cleansers such as hydrogen peroxide, your Dakin's solution, povidone iodine, chlorhexidine, they have been proven to be cytotoxic and basically actually impact healing cells. So we know that all of this exists. And you can see here that with all of these, I'm using this other slide here. I have two screens, so that's why I keep moving back and forth. But you can see there's a number of international guidelines and consensus guidelines from 2019 to 2025. And these are the general gaps that have come up throughout all of these guidelines. So it's not coming from one person. We know that these exist. One of them, wound hygiene, which was again spearheaded by Dr. Chris Murphy out of Ottawa, has identified that wound hygiene consists of 4 key steps or 4 key elements. You can see here, number 1 is cleansing. So cleaning both the wound bed to remove devitalized tissue, debris, biofilm, the surrounding peri-wound skin to eliminate dead skin, callus, and contaminants. Debridement, that's a really important thing. We're really focused, I think we do a good job for the most part on debridement when we have the available resources and ability to actually debride the patients. Refashioning is the third, which involves trimming the wound edges to remove any crust or overhanging that might harbor biofilm and promote alignment for better healing, right? So wound edges are important, as well as anti-biofilm. So making sure that whatever we're using is anti-biofilm and or antimicrobial agents that are encouraged to reduce residual biofilm and prevent regrowth. So together, these 4 help to do that. Our focus really is around the cleansing piece. The International Wound Infection Institute, IWII, came out with the Therapeutic Wound and Skin Cleansing Clinical Evidence and Recommendations 2025. And there's a QR code that you'll get at that's available to you at the end of my talk, my part of the speech, and then you can access and download the document. But the IWI recommends that all wounds, doesn't matter which wound, all wounds, including the wound edge and the peri-wound, be therapeutically cleansed. And so they went further and they actually defined what therapeutic wound cleansing is, which is very helpful because now we have a standardized definition on how we are to clean our wounds. So it's the active removal of surface contaminants, loose debris, non-attached, non-viable tissue, and/or remnants of previous dressings from the wound and the peri-wound. So basically, what we're saying is that we want to get rid of all that crusty, crappy stuff that's in the wound and around the wound so that we can support the body's ability to heal. So we're defining therapeutic cleansing. And then does that mean that there's non-therapeutic cleansing? Emerging evidence says absolutely, because the dribbling with a saline bullet or the 10 ml syringe is not therapeutic. Anointing, dabbling, spritzing, or spraying are not therapeutic techniques. And we'll get into this later. There are non-therapeutic cleansers as well. So the IWII, why it's hard to say today anyway, recommends, as I mentioned, all wounds, including wound edge and peri-wound, be therapeutically cleansed. And so these are a summary of some of the guidelines or recommendations that they have. Wounds should be cleansed with an inert solution at every dressing change and before collecting samples for analysis. Effective cleansing disrupts biofilm. Very important. We know that it is a real problem, and it supports healing. Saline or water alone are not enough to disrupt biofilm. Intentional cleansing prepares the wound for debridement. As you remember from the wound hygiene, those 4 key elements. Cleansing prepares the wound for debridement, for refashioning, and also for helping to be anti-biofilm, and it protects the peri-wound skin from contamination. Your chronic wound exudate contains, this is a really important refresh, chronic wound exudate contains MMPs that actually cause and trigger chronic inflammation. They actually help to promote and support the growth of pathogens and biofilm. And so in order to get rid of that, we want to make sure that the guidelines that we have effective solutions for the wound as well as for the surrounding skin. Antiseptic solutions have shown via fluorescent imaging do reduce bacterial loads much more effectively than saline. And then the the International Wound Infection Institute supports cleansing at each dressing change, even if frequency guidelines are still evolving. So you remove that dressing, you need to be therapeutically cleansing. So what does therapeutic cleansing look like? They have identified 3 therapeutic cleansing zones. And I have to say that you know, when I learned when I was introduced to the new guidelines, I went, oh my gosh, this is like a blinding flash of the obvious. Why did I not think about this? We do this kind of cleansing for our patients that have a PICC line or a peripheral line or any kind of IV catheter. We clean from the exit site out and anything that's under that dressing, right? Because we want to make sure we reduce the risk of transient microflora growing under that dressing. And yet we haven't really done that with wound care. At least I haven't. And so this is a new one for me, looking at not only the wound edge here, which they have defined, the peri-wound, they defined as 4 centimeters. Please don't go out and get a wound measuring stick to make sure that you have 4 centimeters. We're going to ballpark that, but we want the peri-wound is what is attached or in close proximity to the wound edge. And then your surrounding skin, which is about 20 centimeters, or basically the skin that is anywhere from 10 to 20 centimeters away from the wound edge, or that is covered by the dressing. So whichever one is larger. So when I'm teaching using antiseptics for wound cleansing as well as for IV, I say go big or go home. It's not going to hurt to go bigger. It may actually increase a patient's risk if we go smaller. So I find that this is really helpful to be able to make sure that we're doing a large area in order to reduce the risk of potential infection. Because bacteria, we know that there's transient microflora on the skin, and that can travel. And we'll talk about a study that was done not that long ago that demonstrates that. So you don't want to miss what you cannot see. So, if you look at this picture on my left here, you can see the dressing outline. Historically, I think most of us have just been focusing on the wound itself and maybe around the wound edges and a little bit out here, right? And when you look at the fluorescent imaging, you can see that by just cleaning that area, all of this red is actually bacteria. So live active bacteria. So I don't know about you, but I don't have fluorescent imaging available to me. But we want to make sure that we're going to assume that it is there. You can and should treat what you assume to be there, rather than thinking, well, it looks okay, because we can't see biofilm, but we know that it's there, right? So it's the same principle. And so you can see after therapeutic cleansing, going all the way around all 3 zones, you can see that there's no active bacteria here. And that's a critical point for us when we're looking at how we can help to move our patients towards healing, is to, again, start to use therapeutic cleansing, focusing on those zones. The other piece to that is also limb and foot hygiene. So I have these 2 pictures that are seen in practice. So you can see that, somewhere in here, there's a wound in this that's been hidden by all of this flaky crust on this leg. And you can see this foot here, very, very dirty. We know that there's there. We had one patient not that long ago that had a foot that looked similar to this. We got the foot care nurse in, cut the toenails, and there were little living critters coming out of the toes, so out of the nails. So that's not conducive to reducing infection or helping to heal. We want to make sure that we're cleansing and drying the affected limb to achieve and maintain skin integrity. We want to gently clean that daily if possible. If compression's used, cleanse at each wrap change. You want to use a pH balanced skin cleanser and moisturizers, and you want to include the feet and the toes. You want to get in those toes. You want to do what the IWII is referring to as toe flossing. So you want to be going in there and scrubbing in between those toes to get all of that dirt out. Because bacteria will reside. There's all kinds of lovely pathogens that thrive under the skin and under this crust. And so we want to remove that. Okay, this picture here is somebody who works in the bush, does his own care, and he was told to focus on making sure that he did his wound dressing. But you can see there's all kinds of flaky stuff here in between his toes here that needs to be addressed. So we want to make sure that we're not just focusing on the wound in those 3 zones, but when we have somebody with a venous leg ulcer, we clean the leg. If they have a diabetic foot ulcer, you need to clean the foot. The other thing is, of course, location, location, location. So here's one of my patients here. You can see that it's a sacral ulcer. And when we look at those 3 zones, here's the anus. This person is fecally incontinent. And each time I went in to do a consult, The dressing, and of course, this whole area down here had fecal contamination on it. And most of the time they might use a skin cleanser, or they might just use water and soap, or they might just use the cloth and just wipe off the feces. But the thing is that bacteria are still there. We can't see them, but again, we're going to assume that they're there. And so making sure that we clean this whole area is significant in helping to reduce infection risk. And we do that because we want to, failing to prepare means preparing to fail. So that cleansing piece is really an important step in order to do all those other things that we need to do, like debridement, refashioning, antibiofilm, proper dressings, those kinds of things. So the next poll is, what wound treatment solutions are readily available to you in your practice? So we're going to find out what's going on in your workplace before we talk about all the different types of solutions that are being recommended by these international guidelines. So choose all that apply. So we've got acetic acid, chlorhexidine, Dakins, hypochlorous acid, octendidine, PHMB, povidone iodine, and any others that you have. How are we doing, Troy? I'm good.
Sorry about that. We've got them in the chat there. It is launched in front of everyone there. I apologize for the slight delay. So definitely put those results in. They're coming in quick here. So we'll just give it a couple more seconds. Thank you for those who also answered in the chat there. We'll also keep in mind those in the report afterwards too. All right, just a couple more seconds here. All righty, we're almost at about 60% participated now. So we'll show you the results there and you should be able to see it on your screen.
Okay, so we have acetic acid 30%, chlorhexidine 73%, Dakins 11%, hypochlorous acid 53%, PHMB 17%, povidone iodine 86%, no surprise there. And we have 38% other. Maybe whoever put other, you can put those others in the chat. That would be really helpful for us. We can take a look at that after. Okay, so which one to choose, right? Considerations when you're looking at a cleansing solution. And so from the international recommendations, the considerations include the type of wound dressing procedure and therapeutic technique that we're going to be using, and I'll talk about that in a bit. Characteristics of the wound, the risk and or presence of infection, the abundance and species of microorganisms present, cytotoxicity and allergenicity, allergies, promoting optimal pH, goals of care, and other factors related to the person themselves, product information, local policies, resources, and availability. So a lot of considerations. So the characteristics of the wound, the risk of infection. So as I mentioned with the zones, so thinking about feces, bacteria are not removed when wiping the visible stool off skin. So all of those things are something that you want to consider. The one piece that, again, we're looking at a solution, and realistically, we also have to look at our work and the environment where we work, and who's going to be doing those dressing changes. So how can we keep it simple as well? So I want to just plant that seed, and we'll talk about that in a few more minutes. So saline, normal saline is not, as I mentioned already, it doesn't do anything for bacteria. It's great if you're looking at loose visible debris, but how you actually do that technique is important as well. But we talk about legacy behavior. We've always done it. We have saline, it's there, it's free from the government, it's safe. But as from a similar wound infection rates, when we're looking at tap water, from an antibiofilm, from wound infection reduction or prevention, if anything, there is a risk because the lack of compliance with open bottles, regardless if the bottle is 500 or 100, it's single use. So the end of May, I went into long-term care to do some consults. It's the first time I'd been there. They pulled out their wound cart. It looked great. It was so well organized. I'm like, oh my gosh, this is lovely. And then I looked on the side where they had all their solutions, and they had a solution, and it was dated. It was dated May 1st. And I was there, I think, May 27th or 8th. So, you can grow a lot of really weird and wonky things, and that saline, same with betadine, those multi-use bottles, there are weird and wonky Pseudomonas strains that grow in betadine over time. So that lack of compliance actually increases our patient's risk of infection. So when we think about, non-antiseptic versus antiseptic solutions, cleansers with antiseptic properties led to a significant reduction in bacteria than non-antiseptic surfactants like saline and soap and water. Okay. The super important part of this Oro Paulo's study is that while she found no statistically significant germ removal efficacy with the antiseptics that she was using, which was Dakins, Protozoan, Vashe, povidone iodine, acetic acid. What she did find was that both saline and soap and water had minimal or no effect on germ levels. In fact, however, if you can see here in this picture, here's the wound. This is after cleansing the wound, and then the peri-wound. And you can see here that what is happening is that saline seemed to show an increase in germ level post-cleansing, likely by exposing germs in the peri-wound during scrubbing process. And these germs could not be removed by saline and likely were transferred into the wound. So saline cleansing could potentially impact wound healing if we're only using saline without something else. How do we select the best antiseptic cleanser, right? So while there's no statistically significant difference between all of these, we want to use the tiebreakers, which are the cytotoxicity, the debridement, as well as the pH. So this list here includes the different solutions that we have historically been using. Many of the products we use every day are lacking data or cannot be validated, and only a handful have enough data to make a decision on. So when we look at safety, efficacy, pH of the human skin, and the guidelines, all those ones that I showed you in that picture earlier, you can see that Dakins, yes, it works, but it's not safe. And the pH is actually non-conducive to human skin. So it actually is more on the alkaline side. Saline is safe. It's okay because it's isotonic, but again, there's no efficacy. Chlorhexidine. So when you can see here, we're looking at the safety piece is the cytotoxicity of the product. The pH, because pH matters, and I'll talk about that in a few seconds. And then, of course, none of these are recommended as a therapeutic wound cleanser for all of the recommendations that I've shown you so far. So these solutions that we're using are really doing more harm than good. Hypochlorous acid has a high therapeutic index across the board that we're aware of, and I'll talk about that right now. Because when we think about pure hypochlorous acid, it's a naturally occurring reactive oxygen species, ROS, and it meets the highest standards of safety and efficacy. It's one solution that has been identified to excel in those three tiebreakers. Cytotoxicity was one, debridement, as well as pH. It has the ideal acidic pH for human skin, which is around 5.5. So it moves the pH of the wound bed more towards acidic. It is recommended in all 7 guidelines. It has a high therapeutic index and is known to amplify standalone debridement methods. So you're looking at, you've got a trifecta here with regards to a product that can not only reduce the microbial load, lowers the pH, and also helps to support debridement. So your hydrogen peroxide, sodium hypochlorite, all of those, we all know that they really are not conducive to supporting wound healing because they affect fibroblasts and macrophages and all those other lovely cells that we need for wound closure. Okay. Way back, I showed you that information from the study that Doctors LeBlanc and Wu did, and where a number of clinicians felt that hypochlorous acid and hypochlorite were the same. Well, they have both. They have potent antimicrobial activity, as you can see here. Hypochlorite, Dakins, is cytotoxic and possesses a low therapeutic index versus hypochlorous acid that actually meets all three needs that we're looking at. Whoops, sorry, went a little happy there. Did I do that one? Yes, I did. Sorry. Close your eyes. Okay, so pure hypochlorous acid is actually something that is produced by the body as a natural response to pathogens. So our body produces this. It's generated within the white blood cells. Hypochlorous acid is a natural defense. And as you can see here, once the pathogen enters the body, our system produces hypochlorous acid to actually counteract the effect of or to kill off the pathogen. So if it's in our body, it is relatively safe. However, let's look at what they've done. So you can see this eye chart confirms that hypochlorous acid is proven against fungi, spores, viruses, multi-drug resistant bacteria. This list is not exhaustive. However, it includes many of the key offenders that we want to eliminate within the wound, including MRSA, VRE, Pseudomonas, staph, and even C. diff. So these tests were done on planktonic free-floating germs, which explains the short exposure time in which these germs die when in contact with Vashe or any other antimicrobial. In general, tests of germs outside this list have never failed to show that Vashe is able to kill the germs on contact, has never failed to show that the germs have been killed on contact. However, it is true that germs in a tissue environment behave differently than a test tube, and we'll discuss that in a little bit more detail right now. If I can get my thing to move. Okay. And I can't get my slides to move. There we go. Sorry about that. Okay. So as you can see here, comparative cytotoxicity testing of hypochlorous acid and commonly used wound irrigants in this chart here. Hopefully you can see it. So this is, we can see cell survival, which is fibroblasts and keratinocytes, greater than 75% survive when exposed to hypochlorous acid. Saline, of course, the same because it's inert. But when we look at Dakin's solution 0.5, 0.25, chlorhexidine, hydrogen peroxide, providone iodine, 7.5 or 10%, they're all less than 25% survival. So this demonstrates, again, confirms that, Vashe and saline pass the cytotoxicity testing, but all of these others do not. Yet we use them because they're there, they're cheap, they're cheerful. Well, actually, they're not. They're cheap, and it's what we've been using all along. I wanted to say one other thing about the pH to wound healing, is that hypochlorous acid's impact on pH is really helps, again, to move wounds toward healing. As you can see from this chart, chronic wounds have an alkaline pH, and that results in pathogenic proliferation. So it supports bacteria growth, supports biofilm development. It also provides a chronic inflammatory state. Wounds that have a more acidic pH are more favorable to wound healing. It's similar to skin. So a pH of less than 7, 5.5, 4, those kinds of things, that actually makes the wound environment hostile to bacteria. They're very sensitive to pH. So when the pH is anything less than 6, then they start to die off or they become senescent. So hypochlorous acid lowers the pH, making the wound environment hostile, disrupts biofilm. As you can see, it increases macrophage and fibroblastic activity. And so using hypochlorous acid as a therapeutic wound cleanser, you move the wound towards a favorable environment for wound healing. And so you can see here on the left, acidic pH, oxygen releases into the wound, we get angiogenesis. All of these things that you can read here those are favorable to wound healing. On the left, when we have an alkaline pH, you've got microbial proliferation, infection rates, biofilm formation, so all the things that are going to stall the wound. Okay, so we've talked about solutions, we've talked a bit about techniques, zones for therapeutic cleaning. So how do we apply these concepts? Oh, good. Okay, I'm on time. Great. So I know this is a bit of a busy chart, so I just wanted to reinforce that when you download the document, this chart is in there, and on the top part where you can see here the healing, contamination, colonization, this is the amount of bacteria in a wound. And on the left here, we have this column, we talk about wound cleansing solutions, the intensity of the cleansing, the techniques, the equipment's needed, and skin cleansing. So this chart's just, I really like this. To me, this is a game changer as far as being able to put this into practice. Because when you're looking at a wound that's healing, you can use saline because the wound's close, you've got granulation, you're moving towards epithelialization. You don't really need to be there's no debris or crust or crap in the wound. So we don't need to be doing those kinds of things, right? We don't need to be aggressive to try and remove that stuff. So you can see here that with the equipment, you're looking at cleansing wipes and cloths, irrigation equipment, cleansing pads, microfilament pad, gauze, whatever is going to work for you. But as you can see, as you move towards local wound infection, we're looking at the wound cleansing solutions that you want for therapeutic wound cleansing is antiseptics, surfactants. You can use inert solutions as well because you can use those together, but you don't want to just use those. Like you don't want to be using saline alone when you have signs of colonization and local wound infection or spreading infection. In those cases, you want to be using a cleansing intensity. So we're going to be trying to remove some of that visible stuff. It's not really debridement, but this can help support debridement. And you can see that all of these different techniques, therapeutic cleansing, irrigation, soaking, compress, swabbing, scrubbing, mechanical action, installation, hydro-responsive dressings are all ones that you want to use when you identifying early signs and later signs of infection. So you want to select a wound cleansing solution based on the type of wound dressing that we talked about before, right? The characteristics of the wound, the risk and or presence of infection, the amount and of course profile of the infection. So are we moving towards local and deep tissue infection? And of course, always thinking of that trifecta. So cytotoxicity, pH, and debridement. Okay. So optimal wound care, getting back and bringing us back to when we looked at the wound hygiene, optimal wound care includes therapeutic cleansing. It's a key component and it's just as important as debridement, wound dressings to optimize wound care. Think back to that wound. Yeah, so I mentioned about Dr. Murphy's wound hygiene. They're all included in here. Our therapeutic wound cleansing, debridement, wound dressings, refashioning. So all of those together help to remove organic and inorganic debris, remove loose necrotic non-viable tissue, reduce excessive wound exudate, reduce microbial burden, and also contributes to hydration. So that's the other piece when you're looking at therapeutic solutions, that they help to hydrate the wound. So help to remove that desiccation that's there as well. So the goal always, and everything that we do for our wounds, is to rebalance the wound environment and move it towards a healing state. Okay, and so this diagram is also in the document, and I really like it because it really just again brings out the holistic care of the individual and looks at all of these parts together and why they're so important. So I want to share with you, this is a patient, one of the patients. We were using Vashe, and we thought, like Vashe seems to be removing a lot of this slough, and besides the fact that patients like the smell. But the study that we did, it was a case series. So we had 10 patients, all venous leg ulcers. And we patients where we just used Vashe. We didn't change anything else as far as their wound protocol. What we did was instead of using saline, we used Vashe for 5 minutes. So we did a 5-minute soak. Now, at the time that we did this, we did not know about the extensive zone 3, but we did apply the compress so that it was actually fit over the entire peri-wound area. As you can see here, in 4 weeks, this patient had this wound for over 15 weeks. Nothing was happening. You can see it's pretty dry. And then within 30 days, you can see we're starting to see a lot of granulation tissue. We're seeing some, most of that really hard, crusty stuff has been removed. And the only thing we changed was using Vashe. Everything else was the same. They were on compression. We found that within a 4-week period, we had 6 of our patients had a reduction in wound surface area on an average 16% within 4 weeks, which is pretty good for us. And then we had 5 patients showed an average of 20% increase in granulation. So using the chart, the measurement as far as yellow, red, and black. And so this just demonstrates the efficacy of Vashe as a compress and a cleanse in conjunction with whatever protocol that were being used. So it really, we had one patient that had an 80% reduction in wound surface area within 4 weeks, just using the Vashe. So just think if you use it with integral debridement, when you use it with other products that will help to support or antibiofilm products, you could really help to accelerate wound closure. So therapeutic wound cleansing is actually visible. So as you can see, we have this wound here that has lots of gunky stuff in it. And by doing a therapeutic wound cleanse, we now have tissue that we can start to move towards closure. Yes, it's bumpy, and yes, we need some other stuff, but all of this crusty debris and slime that's in there has been removed so that we can help support wound healing using the other techniques that we're talking about with debridement, refashioning, and of course, products. Next poll, this is our last one. Again, putting it in the chat. What is your biggest challenge in implementing therapeutic wound cleansing in your facility?
And we're getting some great message here. Time and education costs, lack of education and reaching or training all the staff, lack of education or clinician buy-in, education, the cost, staff education, time, money, lack of knowledge, consistency, staff knowledge deficit, non-compliant clients to the clinic, getting them to the clinic. Not all the staff are following protocols, turnover of staff as well. That's another good one there too. Surgeon buy-in, lack of education, supplies, time, continuity of care, product delivery, consistency between clinicians and health teaching and education, of course. Only have Vashe being recommended by the NSWAC. Sometimes I guess only available with the NSWAC recommendation from this person. Lack of standardized policies, different opinions based on different consultants. Staff buy-in, lack of wound care consultation, doctors disagreeing, and it comes back to the surgeon piece, lack of buy-in, lack of education for appropriate wound cleanser per wound type. Variances in wound care practices. So lots of great comments here.
Wow, thank you. This is very helpful, and it really speaks to and reinforces similar elements that we heard from the study that Kim and Kevin did with regards to NSWACs. So it's a real challenge when we're trying to empower nurses to standardize wound care and improve healing outcomes and costs. So when we think about key points to healing patients with evidence-based clinical practice includes things like identifying the gaps in current practice, which we know, right? So effective wound cleansing is crucial for promoting healing. So I'm speaking to the choir now because you all know this. So current practices often diverge from guidelines. So we know that. Identifying our gaps, use of saline or cytotoxic solutions because it's cheaper. We've always done it that way. You identified these as really key challenges that we're facing. How do we equip clinicians to do that? And while many nurses use saline and other standard solutions, traditional methods may fall short, right? And then how do we set new expectations? So how can we integrate non-cytotoxic options? And I know that cost is going to be a really big one, and we'll talk about that in a few moments, but there is discrepancies between nurses' beliefs and practices, and it's a real challenge. It's a challenge and I wish I had the answer. I've been in nursing, as Troy said, over 35 years, and That hasn't, it's changed a bit depending upon where we are. But for a lot of us, it's still that challenge in having to um, try to explain or justify our recommendations based on evidence when somebody has been doing something like, surgeons, there's a surgeon where I work, wet to dry dressings, that's it. Yep. And, I'm telling you already, I'm like, oh my gosh, I'm beating my head against a wall. I can't believe I'm still having to do that. Um, but that gap is an urgent need for education and training, and that's what you've identified as a real key one. And um, I don't, again, in just my experience, the staff turnover, um, constantly on a continuous basis, having to re-educate people on key products. There's a reason why when I started this talk, we talked about bundles for infection prevention. Those have taken probably about 20 years to get implemented, and now they're embedded into practice. In fact, they're embedded into quality systems, accreditation, ROPs, those kinds of things. And that might be one of the things that we need to be looking at. So standardizing the process is important. As NSWOCs, you have an opportunity, hopefully, to be able to help guide that process and help to standardize that. Standardizing the product. In the long-term care is where I go and consult. I've negotiated with the directors of care that it actually is cost effective to be using Vashe because we close wounds earlier. It helps to reduce nursing time, even though they're having to soak the wound for, oh my gosh, you mean I have to sit here for 5 to 10 minutes? But when they see the results, we're getting buy-in. So standardizing the product, I try to keep it simple rather than having a whole bunch of some NSWOCs are using 4 different cleansers. Having one that will do the job for 90%, 80 to 90%, 80-20 rule is an option to consider. And then, of course, accessing top-level education. So there are webinars, in-person instruction, there's peer-reviewed journals. How do we move that forward in a more effective way? So Vashe is the market leader. There are over 20 peer-reviewed publications, randomized controlled trials, so significant evidence that supports its use for all wounds. And so it's something to consider. And of course, your ergo rep, the ergo family will be more than happy to give you that information. I've shared a fair amount of that here today. The other piece around when we eliminate a variation, it actually is cost effective. And so Kim LeBlanc talked about this at the conference, and we also had conversations about this individually around when we're working with someone to say, this is by using this, as you can see here, using Vashe for venous leg ulcers, we do, it helps with the quality of life for patients. Our case study of our 10 patients love that product, and we're willing to go buy it themselves rather than not have it anymore. But it does, like look at that one person where 15 weeks and his wound, just cleared up within 4 weeks time with a reduction in wound surface area. So it saves money. And you can see here, this is, if you can get this QR code here, there is a very strong health economic study that demonstrates the cost of care is reduced when we're looking at when using Vashe. And part of I encourage you to help move the trajectory away from the cost of a bottle or the cost of an each to the cost of care, right? We know that it makes a difference. And so moving and having those discussions around the total cost of care, less stress for everyone, decreased length of stay, improves and helps to support nursing time. So it really does save time overall when we standardize our processes and put together a bundle. Here's another study, 24 patients, necrotizing fasciitis, negative pressure wound therapy, people with installation using Vashe instead of saline, cost savings per patient quite significant. And then, of course, complex wounds. So 17 patients. All of these studies are in this available in this QR code. You can see that it does save money and it does improve our patients' outcomes. And so for And for a number of you, long-term care as an exception, but those in community home care, that's where most of their patients with wounds are trying to resolve their wounds. And if some patients, as I mentioned, are willing to pay for their own product if we're finding some pushback from the government or whoever else. But again, there's enough information in that economic study, as well as what you have here and in the IWII document that will help you build a really strong business case to use hypochlorous acid, Vashe, in your practice, because you will see a difference. In one particular long-term care, the nurses and even all the staff saw such a significant improvement in 3 of the patients where I started using Vashe. Nothing else. That was the only change that I made, that they were just like, they went to the director of care en masse and administrator and said, we have to have this. And so, I basically worked myself out of a job because they built a wound care team and they're all gung ho. So every now and then you have a success story that you can share. So you can get Vashe on Amazon, as you can get pretty well anything else on Amazon, but it's available. Okay. So today we talked about gaps between current cleansing practices, evidence-based guidelines resulting in delayed wound closure, increasing patients' risk of infection. Therapeutic wound cleansing is a critical component of wound hygiene to reduce infection, the development of biofilm, and its disruption in the wound bed. The new international guideline recommendations for cleansing solutions includes the use of pure hypochlorous acid. Actually, all 7 of those documents, consensus and guidelines and best practice recommendations, recommend the use of hypochlorous acid. And integrating evidence-based protocols supports a standardized bundled approach to prevent wound infection. I just had a thought. I'm gonna put this out there. Maybe this is something that the NSWAC community can look at, building a set of generic bundles like we have for BAP, for line-associated bloodstream infection, to see how we could help. Maybe that can help us move to a more standardized, consistent practice for all of our patients. Here's the code, and I'm done on that one. So if you use this QR code, you will get a copy of the document. And now I think it's time. Do I have time? Oh dear. Few
Oh,
minutes.
that's
Sorry.
okay. I think we can probably get to a few questions here. And I know Dr. Chakravarty's been in the background answering some great questions, but maybe I'll invite Dr. Chakravarty to come on here if you want to take over. I
I
know
can
there's
stop
still
start. Okay, I'm
still
gonna
tons
start
of great
recording.
questions coming in.
Yeah, I've been trying to answer them. Can you hear me okay?
Yep.
Yes, we can hear you. Great.
Okay, I'll just answer them quickly. When a bottle of Vash is opened, what is the discard date? As long as you cap it well, the shelf life of the product remains good. So use it reasonably fast. You don't want to be having an open bottle there for 18 months.
Yep.
Is it still recommended to irrigate with saline and then apply Vash, or irrigate solely with Vash? What's your view, Karen, quickly?
Um, if there's a lot of debris, like and it's loose, then I will irrigate with saline first, and then I will use a Vashe compress.
Yeah, so that's fine.
Mhm.
I said, I gave an opinion and I said IMHO. Somebody asked, what is IMHO? IMHO is, in my humble opinion. There's a great question. Would normal saline still be preferred cleaning solution for dressing changes of sterile wounds such as C-section incisions? Certainly, when C-sections are made in the OR, it is sterile. However, once the patient comes out, it's anything but sterile. Post incision, after the suturing is done, I recommend, or we recommend, use of Vash on the C-section incision, and we having some great results in having the patients apply Vash at home. Just soothe the place down for a couple of minutes of soak, pat it dry, and do it repeatedly. So you will see some publications in this area coming soon. Watch this
Mhm.
space. What's the viability of packing with Vash soaked gauze for treatment? I leave that question to Karen. Can you go ahead and answer that?
The viability of packing with Vashe for debridement.
Vash
I
soaked
have
gauze
used,
for treatment.
um, So I'm making an assumption you're saying that you're using this as a packing solution?
I
Is
guess the
that correct?
question is, what is that? Is it can it be used for debridement? I can tell you from a compositional perspective, it and from a regulatory perspective too, it can be used for debridement with some mechanical elbow grease. You
Mhm.
need that. The debris ain't gonna remove itself. You're gonna have to push it a little bit. But it's different than saline or water, and that's what I
Right.
think the listener is asking. What do you think, Karen?
I think they're looking at using Vosh as packing instead of saline. And
Okay.
yes, we use that. I do recommend that. And in some cases, I've been able to move some very stalwart, very stubborn surgeons. I've been able to move them from using saline wet to dry dressings to using Vosh.
Okay.
Because that's just one little change. And so when they say, "Oh, this works pretty good," I'm like, "Yeah, it does. It's amazing." But
I,
you have to change it every day, like you
okay,
would
great.
with saline dress. Yeah, you would
Okay.
with saline packing. Mhm.
I really wish this C-sections kit. Please reach out to us. I'd love to work with you to see if it can be used in your facility. And can you clean it with Sprom and then apply Vash? Yes, absolutely. However, because Sprom content will it doesn't have CHG. I don't believe it does. So it'll wash out easily and it's not a problem. But do not put chlorhexidine into your wounds because the molecule is sticky. Chlorhexidine is generally not indicated for full thickness wounds and terribly cytotoxic. You don't want that in the wound. Once you put it in, you can't wash it out with anything. The tissue is contaminated with chlorhexidine for days on end.
Yes.
So just keep
Mhm.
that in mind. What is the recommended soak time on hypochlorous acid? So based on preclinical data, we say that soak it for as long as you can. I think the law of diminishing return kicks in. 2 to 3 minutes, you probably get most of the biofilms attacked by the hypochlorous acid. 4 to 5 minutes is good. After that, it continues to dissipate from the gauze and enter the wound space to keep the wound clean. How long do you keep it wet?
I or um I do I put it in for 5 minutes. I tell everybody just do
Okay.
5 minutes. It's like across the board. And sometimes they, generally some are really diligent and they will actually have a stopwatch, which I just wanna, oh,
Yeah.
so nice.
I think
And
looking
there's
at
like
the
3 to 5 minutes.
yeah.
So yeah, I try to do five just because again, I'm trying to keep the protocol consistent, regardless of.
Sure, sure. I think, it all depends on how thick the gauze is, how much hypochlorous you put. It'll go in through diffusion. And the longer you keep it, and then the good news is the hypochlorous acid is doesn't leave any memory in the as far as we can tell, So you're not building cytotoxicity. It is getting consumed by the organic load, which includes the germs. And then so it's a little bit longer doesn't hurt, a little bit shorter doesn't hurt either. Is PHA safe to use on neonates? I guess you're talking about VASH. Yes, we have a ton of published data on. In fact, there's a very nice book chapter that has been written. I can send you guys the link if you read it. And so it is used all over North
Mhm.
America on neonates, extremely safe. And then it's used for diaperdermatitis, central lines, wherever there's chlorhexidine allergy in central line management. It's used for LVAD entry sites and a lot of data. Please reach out to us and we'll be happy to send that to you. Um, Let me see if there's a couple other questions coming in. Uh,
Dr. D, there's one on using Vosh on mucosal tissue, like vaginal
Oh,
tissue.
yes, absolutely. You can
Mhm.
use it on mucosal tissue. We have mucus data. So on our label, we say it is mucus safe, particularly in the genitals and those areas where
Mhm.
you have intact skin or inflamed skin from MASD or IAD. It's pretty safe on Foley's. You can use it on mucus, and we don't say rinse your eyes and mouth with it because that's not on the indications for use, but we have tested it so that we say it is safe if it does get into the eye or it gets into the mouth.
Yeah.
So perennial care or so thank you. That's a great question. Um, Now, will applying skin prep to the surrounding skin after being cleansed affect the cleansing process? After being cleansed, you can apply the skin prep. That's not a problem, right,
Mhm.
Karen?
Yeah, that's right. Absolutely. It's no
Yeah.
different as long as the skin is visibly dry, then
Right,
yes.
right,
Yes.
right.
Yeah.
The skin prep, because like I said, a Vash leaves no memory, and that is the beautiful part of the product. Okay.
Hmm.
Now, let me see. What makes one brand of hypochlorous acid different from other brands? Listen, we respect all companies and competitors. You got to look at the evidence that they have. They are not all the same solutions to the extent, your different brands or vehicles are not quite the same, are they? I would say that stability and evidence and stability is what you want to look at. uh, we put a lot of resources in proving some of the claims that we make, and formulations matter. We have IP and patent protection on some of the stabilizing things that we have. So they're not all the same. But again, all companies compete in the space, and I respect all their abilities and whatever they bring to the table, it all makes us better. Thank you. That's a great question. Um, is Vash photosensitive? Yeah, great question. It's not actually. The blue color is my marketing colleagues came out with that color, but
Marketing.
it's not. Yes, yes, it's not photosensitive. It's perfectly safe to dispense in transparent medicine cups and give it to patients and stuff like that. It's not photosensitive. Now, that having said that, don't leave it sitting out in the sunlight for days on end. We haven't studies like those done those. Just keep it in like you keep any other medical product under ambient conditions in a nice, cool place in the shade. So that's what you want to do. Let me see. So I think
So
that's about.
Dr. D, there's one question somebody had asked about using CHG prior to debridement. And I know that
Yeah, some of them are coming to the chat portal. Can you address that? I can comment
yes.
on it. What's the
Yep.
question?
It's a lot of doctors here use chlorhexidine prior to debridement. Is that still a standard? It is, but you can use Vashe because I've switched to just using Vashe, and I will soak it for 10 minutes and clean the whole peri-wound and wound edge and everything else with the Vashe before I do debridement.
Yeah, look, chlorhexidine is a life-saving molecule, and
Mm-hmm.
it is. But don't get it into the wound. And if you have got
No.
it into the wound, don't try to rinse it away because it's not coming off. It's got this habit called residual effect, which is great on intact skin. Remember, your skin is stratum corneum covered and it's dead. You cannot kill the top layer of the skin because it's not living, you see? And so then it sheds over a number of days and so on. But it's very sticky to protein. Once you get it into the wound, it'll stick there. And this is what causes the indication that it is not meant for full thickness wounds, not suitable for genital care, not suitable for mucus, a very destructive molecule. But
Mhm.
on intact skin, it absolutely makes a difference to prevent surgical site infection and things of that nature. So that's a great question.
Mhm.
Any other question that I
There's
may
one
have
about, does
missed?
Bosch cause pain when applied to some wounds? In my experience, no. If anything, people find it cooling. I used it. We had a new patient who had some pretty huge circumventional leg wound and is very, very sensitive. And I just soaked some ABD pads with Bosch and put them on. I said, "How does that feel?" She goes, "Oh, that's very cooling." And I went, "Yes," because she was like all psyched out to like think it was going to be painful, but in my experience, it's the actual opposite.
Yeah, any interaction with topical antibiotics? See, Vash leaves no memory. Once you have used it and you've patted the wound dry, you can use any dressing on top of it, including
Mhm.
antibiotics.
Yeah.
Can Vash be used over dry eschar instead of painting it daily with iodine? I think you could. You just need to soak it good on dry eschar. I don't know, Karen. You seem to be
No,
shaking your head.
it's if you're using if you're using betadine as to reduce bacterial proliferation and keep the eschar dry as a protective cover, no, you can't substitute Vashe, because Vashe actually helps, it softens slough, so it would be contraindicated to use on those wounds that are non-healable.
Well, that's fantastic. Nuance to my answer. Is there a protocol for use with hyperdermatitis? Indeed, there is. There is a
Mhm.
publication that's coming
Yep.
out on 100 kids with hyperdermatitis. But if you reach out to us, we'll get you the protocol. It's not difficult at all. You know, little babies' butts, it heals quite dramatically to the relief of the baby and their parents. So this will be very good. Are Vash and silver compatible? Do not pour Vash on a silver dressing, okay? Because that's not how you want to use Vash. But use gauze, the cheapest dressing there is, to deliver Vash to the wound. And then, after you have soaked it good and patted it dry, you can put your favorite silver dressing. So this Vash leaves no memory, and that's a good thing. So that's
Mhm.
moral of the story. So,
I'm glad you
um,
cleared that one up. That's important because people think, I know that you have to rinse hydrophora blue if exposed to Bosch, it'll pull all
then
the
white.
mentioned violet and methylene blue right out.
Right. And is there a maximum amount of days Vash can be used on a wound? No, no. You can continue to use it as long as you like. Leaves no
Mhm.
memory. Do you cleanse wound with normal saline after Vash soak? You don't. Again, leaves no memory. And so this is the theme that this is what makes it differentiated from other molecules such as povidone iodine or chlorhexidine or
Mhm.
iodine and things of that nature. They're all potent antimicrobials. It's the collateral damage that they do on tissue that you need to worry about.
Mhm.
Well, that seems to be the last question of the day, and I hope we have answered all of those.
Well, I just want to say thank you to both of you, and a great participation here. And I'm glad everyone had a chance to ask some of these questions. Thanks for staying on a little bit longer. I know it's speak on behalf of everyone who's saying thank you so much in the chat here, and echo their comments. It's very appreciated. And what a great way to cap off our webinar series for the spring here. And for those who are asking, we are going to be sending the certificate of attendance out to you. Just give us a day or so. I'll get it to you before the end of the week. It'll also include the recording for today's session, where you can find those QR codes and everything. What I might do is from that QR code for the document you shared at the end there, Karen, maybe I'll get the link for it from the IWII site to make it easy for everyone. So we'll put it right in
Okay,
there.
perfect.
And if you
Okay.
do have any further questions or you want to get in touch with Ergo, you can reply to that email. We can always put you in touch. But I'm not sure if Dr. Chakravarty, is there a certain place you want to direct people if they have further questions about Vosh, or they want to get in touch with their rep?
Do
Maybe
we?
just, I'm sure we can just on the Ergo Medical Canada website, I'm sure, but reply to that email that you're going to get with your certificate and with the recording. We can always get you in touch with the Ergo team. That's no problem at all. So on behalf of NSWAC, I want to say thank you, Karen. That was fantastic. Really appreciate you taking the time to go through all this education with us today. And we thank Ergo Medical Canada so much for your continued partnership. We're going to be doing a series of more webinars again, as we said, starting in September again. So we look forward to seeing you there. If you want to look at any of the past webinars we've done with Ergo or with any other of our educational webinars, you can always access those on demand too at our nswoc.ca website under the webinars area. And we've had Karen speak with us before too. So if you want to learn more from her, that's a great
Yeah.
opportunity as well.
Yep.
So
Just reach out to me on LinkedIn. And by all means, I'm more than happy to talk more about my favorite products. Okay.
fantastic.
So yeah, so thank you everyone for such a great participation. It's been a great hour and a bit. So thank you.
Absolutely. All right. Well, have a great evening, everyone. We'll see you at the next webinar in the fall.
Okay.
Bye.
Bye.